A COVID-19 pregnant patient, what we have learned from the pandemic. Not out of the wood yet. I thought this is the pertinent topic to be discussed and I outline background and epidemiology. I would not go into a great detail of clinical management. It's actually provide a drone view on this topic involving obstetric anesthesia. This is the outline, a back-in and obstetric patients. I'm not going to go into great details of clinical management. It's just going to provide you and walk you through the issues involving pregnant patients with COVID-19. And then we're going to look through some of the guidelines and recommendations internationally and locally. What are the mainstays of treatment? And later on, we're going to see. These are all the pandemics that have occurred through the history of the world, and we have witnessed episodes of pandemics now and then. And the earliest one is the Antonine Plague and the Justinians, but the most deadly one was the Black Death back in the middle of 14th century that has claimed about 200 million lives. MERS-CoV and HIV, but others mainly has ended. So the COVID that has come and emerged, there has been Ebola, there has been SARS, and swine flu, and at the eve of the new millennium, we were ambushed by COVID-19, and then the total death toll so far was about 6.4 million. What does emerge? They usually reported from animal vector linked to the pandemic, and how does pregnant patient affected by this pandemic? Normally, pregnant patients are vulnerable population and they are adversely affected by those infections. So what is coronavirus? Coronavirus is a large family of viruses. SARS-CoV-2 virus is a novel coronavirus. We know even though the cross-infection between species are rare, but for the coronavirus infection, COVID infection, it was first identified in Wuhan city at the end of 2019 when there was a cluster of fatal viral pneumonias reported in that city. And it was very contagious. It spreads through close contacts, respiratory droplets and secretions, and also contaminated surfaces. And as people travel the globe, infection spreads as well. So by March 2020, just a few months after its recognition, Europe has been an epicenter of the infection, and WHO has declared a pandemic then. So this is just a timeline. After the first wild variants, there are emergence of other variants with different effect. And by November 2020, WHO has announced this COVID-19 as a pandemic. Just right before the emergence of Delta variant, there has been of vaccines, but it was not on time to catch the Delta variant's emergence. Malaysia, we go through a series of MCOs and we got used to the normal SOPs, physical distancing, masking up, and etc. etc. So there has been a lot of campaigns and infographic to inform the society and disseminate information to create public awareness and to reduce the rate of infection and people at risk. So one of it is pregnant patients. So how does COVID-19 pandemic affect the obstetric population? So we witness an horrific effect of COVID-19, especially during the Delta waves, where there are too many good ones left too soon, and leaving many sad stories behind and affect us as a medical practitioner as well. This is UK Embrace. It's a rapid report. Normally, Embrace is a triennial report, but due to the pressing issues of COVID-19, they give the perspective of COVID-19 towards pregnant patients. As we can see there, about 1,400 plus were admitted to the hospital. 96% were unvaccinated, and 30s women get admitted into the intensive care. Almost 97% of them were unvaccinated. So this is a very strong message for vaccination. This is Malaysia, kadar kematian ibu. This is MMR ratio from 1930s to 1922, 2022, we observe a rapid plunge of MMR since 1933 to about 1990s. But after that, our MMR has plateaued. So we did not achieve our Millennium Developmental Goal 5, that is to achieve 2/3 of reduction of MMR from 1915, which is we should achieve about 11 per 100,000 live birth, but our MMR has 5 per 100,000 live birth. Since the MMR for 2021 has not been published yet, what we expect 19 deaths. So it has been estimated a rough figure from the 2021 MMR. Among all the maternal death, 41% was contributed by COVID-19 death. So about half of the MMR last year were due to COVID. And we see a surge of COVID-19 cases in pregnant mother in conjunction with the surge of COVID-19 infection with the general population during August time. So this is status jangkitan COVID di kalangan ibu hamil di Malaysia. Since the start of the pandemic, maternal death and all of those 21 and touch wood in 22 death yet due to COVID. So this is partly because of a ramp vaccination program. During that time, the Delta wave, 79% of our mothers were not vaccinated, even though our national vaccination program has taken off much earlier. But the hesitancy to start vaccination for maternal obstetric patient was there because due to safety reasons for the mother and the baby. And 83% of them has comorbidities such as obesity, diabetes and hypertension. So does pregnant patient has a higher risk for COVID-19 infection? No, actually they have the same risk as a non-pregnant population or as a general population. But and majority of them are asymptomatic as well. The disease, they tend to be at risk or having a risk factor for having a severe infection or risk for hospitalization. So of course, we know obesity, comorbidities, unvaccinated pregnant mothers are at high risk, and maternal age sadly is put at more than 35. And socio-economic deprived population and minority ethnic groups. The CDC update on December 2020 had recognized the pregnant patient as a higher risk group when contracting COVID, and they are known to require a hospitalization and worse overall maternal outcome. The last updated ones in July 2021, it is known that 5.4 pregnant patients are 5.4 times more likely to be admitted to the ICU and 1.7 times back to the non-pregnant counterparts. But come to think about it, when we manage a COVID pregnant patients, we tend to be very cautious, and the admission to the ICU itself sometimes reflect a lower threshold of admitting them to the intensive care rather than that patient having a severe disease. I'll say that as the comparison between Delta variant and other variants, the admission ratio to ICU was higher for the Delta. Even though Omicron confers a milder disease, but they are more infectious. So the total overall number of infection is higher, so that would actually somehow be patient at high risk because more of them getting infected. And there was concern of vertical transmission as well, and it is known that COVID-19 students of congenital abnormalities. But there is increased risk for stillbirth for pregnant mothers, and they have small for gestational age babies, and increased risk for preterm delivery. Some of it can be iatrogenic, especially during the earlier phase of the COVID infection, where we perform cesarean section for maternal resuscitation and to assist ventilation. But towards the later phase, when they have a milder disease, so this is become rarer now. There is also increase in issues with perinatal health disorders such as anxiety and depression, and it is known that during the MCOs and lockdown there are violence. So how does Pregnant patients presentation are just as like any other non-pregnant patient, and we categorize the presentation into 5 categories and subdivide, risk stratify the patient and assist in the management of patient. And it is important to recognize red flags, signs and symptoms so that we can escalate treatment and refer them appropriately. So initially we thought that COVID-19 is just a respiratory disease, just a flu. But it is not. We know that it is a complex disease with clinical phases of progression, and it involves multi-organs and heterogeneous disease. So special consideration in obstetric patients include, does it transmitted via the placenta and infect the baby, or what about thrombotic, especially in pregnant patients who are actually pro-thrombotic state, so on and so forth. And then the normal symptoms of pregnancy such as shortness of breath, fatigue, lethargy can be mistaken as COVID-19 infection as well. So these are some of the red flag signs. You can find this in the MOH guidelines. This actually to help recognize potential or progression of a disease into severe state and escalation of care, and appropriate referrals can be done and involving multidisciplinary team and of course intensive care input. So guidelines, the situations were very fluid during the beginning of the pandemic until we got confused. We have new guidelines within a week, so dissemination of information difficult at that time. And then the multitude of chaos actually worldwide. So WHO has tried to compile all these recommendations and come up with what should be done and what should not be done, and as well as bodies. Oh, I still have a lot to go. This is Malaysia, okay, Annex 23 in our MOH guidelines. Revisions, and then the last one was in April 2022 published, Annex 23A. So initially the emphasis was on doffing and donning for all healthcare workers, screening and cohorting our patients, and we create a dedicated team for COVID-19 need for negative pressure rooms at that time to cater for labouring mothers. And there has been suspension of husband-friendly policies. A husband cannot go into the labour room, and limitation of number of antenatal visits to the clinic so that ensure this social distancing, and so on and so forth. From the initial recommendation, breastfeeding has been withheld with concerns of transmitting COVID, but later that has been revised. And we have identified dedicated OTs, making barriers and discussions with engineering team to make sure safety of the patient and safety of the healthcare as well. And the challenges, of course, managing both COVID and non-COVID within the same hospital and separating them. So mainstay of treatment, vaccination is a way to go. Recognizing red flags, oxygen therapy, radiotherapy, and then a prone positioning in patient. And decision for time of delivery, whether you should deliver them earlier or is it according to the time by the obstetric indications. Should you provide GA original for COVID-19 patients, and role of steroids, thromboembolism prophylaxis, and so on and so forth. So support ventilation, majority of them are asymptomatics. So you escalate your therapy according to patient symptoms, trying to achieve SpO2 of more than 94. And escalate not be withheld, especially with the decision for radiology or imaging because they are pregnant. And prone positioning has been known to use in management of ARDS in adult patient, non-pregnant patient, to improve oxygenation. But doing uterus is quite tricky. Initially, they were advised to on a lateral position, but later we have modified. Role of steroids. We know steroids has a role in severe sepsis, but how do we extrapolate this in obstetric population? Well, dexamethasone has been used for lung maturity for obstetric indications, and this can be used in the treatment of COVID as well. So you use DEXA when there is an obstetric indication as well, but without the obstetric indication, there's no indication for early deliveries, so the normal steroid can be used. Thromboprophylaxis is important because prothrombotic COVID-19 as well as compounded by obstetric. Immunomodulators has been used, but the kick off quite late as compared to the normal. Now it has been shown that it has a lot of good deeds when you start on these immunomodulators. Antivirals, but these are the drugs that has shown no benefit in the treatment of COVID. And then come Paxlovid, yeah. But this is very new and it's not a magic drug. It has a lot of drug-drug interactions and it's not approved for obstetric use yet. So the admission to HDU or ICU is not an indication for emergency delivery. Yeah, this is one of the emergency caesar that we did in our ICU because of deterioration of maternal condition. Even though the view outside the window is very nice there, but the emotions in that room was very gloomy. And that, okay, timing of deliveries, okay, initially the high panic. Now we know that we can get away without it, and because of the milder disease, there's no need for delivery to expedite the delivery. Decision to deliver should be multidisciplinary orientated and involve consultants across all disciplines and should involve senior and experienced level of care. And sometimes we do resuscitative hysterotomy to resuscitate collapsed parturients. This is recommendations coming from a few prominent bodies in obstetric regarding the mode of deliveries. Most of them agrees that it is per obstetric indication. But in contrast to the earlier Malaysian guidelines, on your left side, the red box, okay, they said that section as a mode of delivery until even up to April to 2021, Caesar is still advised for patients with COVID-19. But later on, with the now it has said that the indication is per obstetric only. And we can wait for elective cesarean section until patient comes to term because they have milder disease. The quarantine period is shorter now, so we are able to postpone the surgery a week or two later. So do we perform GA original for them? It depends. If they are already been ventilated, of course it's a GA. But if the indication for regional is as any other patients, we rule out all the contraindications. So if there is no contraindications, no low platelet, hemodynamically stable, single shot spinal, CSE or epidural top-up can be used. And aerosolization when we perform GA process. But bear in mind, doing is not easy. Especially in our population where there is a lot of obese patients, so you need an experienced person to do this. So it avoids all the disadvantages of GA. What about the use of NSAIDs? Across board, the decision is actually quite divided. Actually, some of them suggest to use NSAID as a additive analgesia, but most of them advise against it because the COVID-19 presentation with renal failure and low platelets, so it's not advisable. But tranexamic acid, you can use it, PPH, so there is no contraindication for it. What about labor analgesia? Most of them advise early and those laboring mothers. And in UK, it has been shown that when you provide early labor analgesia, they have cut down the incidence of needing to provide general anesthesia for emergency section and avoid all the problems with GA. Anthenox, the decision was also divided. Some of them say you can use, some of them say you cannot use, some of them say you can use with filters. So, but PCA, fentanyl, opiates, PCA and remifentanil are not advised because the risk of desaturation. Okay, when we do a lot of regionals, of course, there are going to be increase in incidence of PDPH. So the first line management, conservative management of PDPH still applies to hydrate the patient. But what is the issue if the patient does not respond to the initial conservative management? So the evidence is quite a few case reports came showing the safe role of epidural blood patch, but of course you need to rule out other contraindication, and especially if the patient is on anticoagulant. I normally proceed to sphenopalatine ganglion block first before I proceed to EBP. So can I do SPG in my obstetric patient? The consensus is no, because it creates sterilization. So EBP is recommended, so SPG is contraindicated. Vaccination, need no more saying about it. Effectgram has been launched. They even advise husband to encourage their wives to take vaccination. But this is program Imunisasi Malaysia, launched in June 2021. Asian program among pregnant mothers, and evidenced by MySejahtera registration for pregnant mothers registered for immunization about 90+%, and as well as completion of the vaccination dose is very high, impressive. And it has been a major contributing factor in declining of maternal death COVID-19, especially in 2022. So now moving on from pandemic to endemic, okay, 2 years of struggle to be on top, but we realize now that the COVID would not go away so soon. So how we can learn to live with COVID, adherence to hygiene, public social distancing, and so on and so forth. And we also recognize the importance of mental health issues, burnout, stress. It shouldn't be taken lightly, and special support group should be referred to for appropriate professional. And then during the initial phase, we overflown with admissions, and mainly all pregnant mothers need to be admitted, but later on, as in an Omicron wave, we see a more milder disease. They are able to be monitored at home, so this reduced the burden of healthcare facilities. Strengthening of policies is important, especially for vaccination. As guidelines and protocol every now and then, and as the evidence emerges, and we need researchers for it. Equality of vaccine distribution, and that is something COVID syndrome. Many has coined different terminology of it. Basically, is presented as SOB fatigue, cognitive dysfunction, brain fog, and so on and so forth. So, summary, okay. Before I leave the stage, I would like to conclude. Mask up, public measures, public health measures works. This social distancing, and COVID-19 is just not just a flu. Obstetric patients are at higher risk, and they tend to get sicker diseases. Poor pregnancy outcomes if pregnant mothers contracted with COVID. Medications and prone positioning can be used. Vaccine is a powerful tool. That's the way to go. And SVD, anesthesia if they come for cesarean section. Neuroaxia blockade is okay for analgesia in labor. Breastfeeding is okay. And endemic and rapid. If you are interested, you can go through this systemic review. And we deserve a pat on our shoulders for all the hard work, sweat and tears that we go through, thriving through the pandemic. And hopefully it has taught us to be more prepared for future unprecedented times. With that, I thank you.